AI in orthodontics. Where are we now and where are we going? Welcome to this episode of Orthodontics in Summary. Today's topic takes artificial intelligence and we look at its clinical application currently, but also what's on the horizons as to what AI could offer. This is one of my favourite topics from this year's American Association of Orthodontics meeting, and I'm summarising 3 lectures today. We're going to look at the lecture given by Juan Gonzalez, as well as Marc Retrouvey, Tarek ElShebiny, and Jonas, Bianchi, and Lucia Cevidanes. I'm going to describe what AI is, its applications, but also give my critical view of where this young aspect is within our speciality. So starting off with AI, well, what is it? Well, it's a form of computer and machine learning which enables it to simulate intelligence as a human being. It enables it to perform one task very well. Common examples in life are voice command and social media recommendations. Fundamentally, it is a predictive modeling. It's calculations. Information gets converted, usually into numbers and categories, and enables pattern recognition to take place, from which outcomes can be assessed and also decision making can take place. And that's the fundamentals of it. There are 3 different layers of it, not to get caught up into the technicalities, but there's machine learning, neural networks, and deep learning. In terms of machine learning, it's an overarching idea. It allows the machine or computer to take past data, identify patterns, and to make predictions. Neural networks are an advanced version of this, simulating the human synapse. They're termed nodes in terms of AI, and they're essentially regression analysis which takes place, allowing predictions and probabilities to come out from that data set. When we get multiple neural networks together, this forms deep learning. This is a more complex interaction used between different nodes to assess probabilities and make further decision making. Now, an example of this is taking a bunch of clinical photos and uploading it to AI. That's our input. Now, the AI will convert that information into different numbers. The hidden layer, which is the second stage of AI, calculates and looks at those different variables and identifies things such as overjet and canine relationships. And then we get the output, the identification and labeling of a class 2 or class 3 case, as well as a percentage accuracy of that information. So what's its application in orthodontics? Well, the first is the virtual patient, the idea of getting a scanned data and getting CBCT data, segmenting it and putting it together. Now, in my ignorance, I perceive this to be a relatively straightforward process to take place, but it isn't. Actually, identifying what a tooth is and labeling it accurately does require deep learning, as well as separation of the root from the bone. Now, in terms of where this can be clinically applied, a common example given are of impacted canines. The idea of gaining this data together to then be able to visualize the ideal vector and even use computations to work out what that ideal vector should be. This level of visualization helps us plan the biomechanics. This is my first criticism of this as a process. We get good visibility, we get good analysis, we even get to plan the direction of movement from this. However, it's still left with the clinician to plan the biomechanics for that process. Also, impacted canines are not common, and having this visibility doesn't really impact upon the average case that we are treating. What about the use of CBCT into aligner cases? Well, this was an excellent unpublished thesis as of yet by Tarek ElShebiny, in which they looked at the consequences of having CBCT data in terms of treatment planning. And what they found was the confidence levels of clinicians significantly improved. However, one of the least affected aspects was that of actual treatment planning. So it may be useful to have this data, but not in terms of making clinical decisions, at least as of yet. Other aspects of the use of AI. Well, one of the most commonly used aspects in terms of the literature relates to the use of AI cephalometric tracing. Now, Tarek had a look at this and they used the AAOF legacy data, and he essentially trained a neural network himself to be able to look at this data and analyze different landmarks. They looked at a whole variety of different structures, and in the end they found that there was 46% accurate for 24 landmarks, and that's a reasonable range of error taking place. He also looked at commercial products and found there was a degree of agreement between each one of those companies. However, there was still variation in this identification, and he gave an example of how even seller can be consistently found incorrectly, so still not quite there in terms of its accuracy. Other aspects that we can analyze are facial analysis. Software such as WebKef allows auto analysis to take place. Now, Adele in 2025, this year, carried out some research looking at 7 different facial structured landmarks to see the accuracy of them. She compared that to the use of manual identification and found for the 7 landmarks, 5 were diagnosed accurately through AI. 2 had small differences but not clinically relevant. So it shows from a facial perspective, AI seems to be reasonably accurate in diagnostics. Growth has always been a challenge to predict within orthodontics. With multiple variables, can AI help us? Well, Tarek again did some research on this and found from looking at 300 cephalograms, unfortunately the agreement was still poor when it came to looking at 9-year-olds. It looks as though there's still some complexities there that aren't able to be analysed accurately at this stage. And this is a piece of research that my research team and I have looked into, the diagnostic accuracy of clinical photos using AI. This was led by my then resident Matthew Vaughan, and what we found was that the sensitivity was high at 72%. However, the specificity was low at 54%. Translating that, this means that it would diagnose disease when there was no disease present, indicating that model wasn't accurate enough. What about in terms of a clinical procedure? Well, in terms of looking at bracket positioning, when it's digitally indirect planned versus direct clinical bonding, it was found that for the majority of the teeth, there was a degree of accuracy of less than 0.5 millimeters error. However, there were significant errors in the premolars and the lower lateral incisors. What I liked about Tarek's interpretation of this is that it doesn't mean that we rely upon AI to position our brackets. More so, it means that we are able to focus on the common errors, such as premolars and lateral incisors, in planning our cases. Now, AI is used in remote monitoring. I've discussed this previously in a past podcast, where we have significant repeatability, and the final application of AI is that of bracket removal. Is it possible to take a scan with the brackets in place, remove digitally the brackets, and fabricate a retainer from that STL file? Well, this is exactly the research that Tarek and his group carried out and published in the AJO just last year. And they found that there was a good fit for both the digitally removed brackets and retainers that were fabricated, as well as the analog process. So where does AI within orthodontics fit into AI in dentistry and in medicine at large? Well, in terms of FDA approval, there are only 4 pieces of software that have been approved with AI software in dentistry, and this is because of the strict criteria, but also the accuracy needed when it comes to diagnosis. Of that, it relates mainly to radiology, but interestingly, dental monitoring is one of those pieces of software, as well as Dentsply Sirona, Rayco, and XNav Technologies. It's great to see the American Association getting behind AI, establishing their task force to look at its applications in clinical orthodontics, but also its application in a safe fashion. I loved this quotation by Jean-Marc Retrouvey, and we do not have to become AI engineers. We are not going to be replaced by AI, but what is going to happen is that the orthodontist will be replaced by the orthodontist who uses AI. What's next on the horizons? Well, we need more data sets. At this point in time, there isn't enough information to make these models as accurate. To give an example, it takes between 10,000 and 20,000 images to be able to correctly label and identify the difference between a dog and a cat. So for that, large quantities of data are still needed to refine our models within orthodontics. In terms of future advances, robotics in orthodontics is the next stage. The ability to have robotics make a customized appliance which has a rate limiting step and can change vectors when it is indicated. It's exciting to see what AI has to offer orthodontics. However, we have to bear in mind, unless it significantly improves the clinical outcomes to our patients, or introduces dramatic efficiencies within our clinical practice, it is perhaps how Jonas Bianchi stated, it is just hype. A quick update for me, I had the pleasure to teach at the DTMD University over in Luxembourg just last weekend on my favourite topic of IPR and space creation. I'll also be speaking at this year's British Orthodontic Conference on the 23rd and 24th of September on no less than the topic of artificial intelligence and clinical diagnosis. I'll also be carrying out my IPR hands-on course for the last time this year in London on the 27th of September. As always, please do subscribe and look forward to the next episode.